Okay, so good afternoon, everybody. Thank you for joining our webinar, which is entitled Primary Progressive Aphasia Subtyping in Clinical Practice, and it will be presented today by Rik Vandenberghe from the University Leuven in Belgium. My name is Anja Hermans, and I work at the Institute for Medical Genetics at the University Hospital Tübingen in Germany. And in Tübingen, we are coordinating the European Reference Network for Rare Neurological Diseases, and I'm responsible there for the training activities. So I will give you now a short overview or general information about our webinars. This webinar is part of our joint initiative, jointly organized webinars by the European Academy of Neurology, ourselves, and the European Reference Network for Rare Neuromuscular Diseases. And we always have around 40 to 45 minutes presentation and 15 minutes of questions and answers at the end. So please write your questions in the question and answers. You have to have in the lower toolbar a button, so there you can write your question. We are recording this webinar, so the recorded webinar along with the slides will be put on our website around 2 weeks or at maximum 2 weeks after today. And you can also check another part of our website, which is our knowledge hub on frontotemporal dementia. Your browser at the end of this webinar will open a post-webinar survey. So it would be great if you can fill it. It should take around 2 to 3 minutes, but it gives us a very valuable and precious feedback on how we can further develop our webinars. Okay, so we have something new. From June, we will also have new webinars on neurorehabilitation. And or similarly as the existing ones, they will have adult or pediatric focus. So you can see the full program and register for those webinars by visiting this website. I will put in the chat the links afterwards. And I would just like to give some words on the European reference networks, because we have attendees from all the corners of the world, and maybe not all of you are familiar with the European reference networks. So there are 24 ERNs in Europe, and they are all treating or covering a specific disease type. So there is a European reference network on rare liver diseases, on rare kidney diseases, for example. And we are the European reference network, we are representing the European reference network for rare neurological diseases, ERN-RND. And we have full members hospitals in the dark blue countries and affiliated partners in the light blue countries. And those reference networks are groupings of expert centers. And the goal is to intensify the collaboration and enable knowledge sharing and expertise sharing, which is very important in the field of rare diseases. So our network covers the following 6 disease groups, and today's webinars is part of the disease group frontotemporal dementia. We have, before I introduce our speaker, just a remark. Our webinar today, there will be many audio files, so we have tested the quality of these files, and the quality is very good. So if you cannot hear something, please also check for your audio settings on your personal computer. Okay, so our today's speaker is Rik Vandenberghe from the University Leuven in Belgium. He has obtained his medical degree and his PhD degree at that university, and has spent 1 year at the Cognitive Neurology and Alzheimer Disease Center at the Northwestern University in Chicago, US. And his current position is full professor at the university in Leuven and director of the memory clinic. He's also principal investigator of the Laboratory for Cognitive Neurology. Rik is focusing on clinical care and scientific research for better diagnostics and more efficacious therapeutics in neurodegenerative diseases. They are currently following a total of 543 patients with Alzheimer's disease, 91 patients with frontotemporal degeneration, and 46 patients with clinically probable dementia with Lewy bodies. They are also following a community-recruited longitudinal cohort called Flemish Prevent AD cohort, KU Leuven or FPAC, of deeply phenotyped middle-aged and older adults who all receive molecular PET imaging at baseline. Rik has been principal investigator for several studies with industrial partners. You can see the studies here, which resulted in first author or co-author publications. So we are happy to have him here today. Thank you, Rik, for accepting the invitation. And the floor is yours. I will stop sharing my screen.
Good afternoon. I'm Rik Vandenberghe, as Sanja already mentioned. So the topic of today is primary progressive aphasia subtyping in clinical practice. In our first questions, we would like to know you better and of which discipline you are. So Sanja will put up the questions, and so you are invited to let us know to which group you belong.
Okay, the poll is running. Okay, 15 seconds left. Okay, thank you for voting. I will show the results.
All right, you close, Sanja?
Yes, yes.
Okay, so let's start. So do I need to close this?
No, you just go ahead with the arrows and you can, yeah.
So the learning objectives of today's presentation is to clinically characterize language and speech problems in patients presenting to the clinic. And so the main emphasis of this presentation is which tests you as a clinician can do in order to analyze which functions are affected in patients presenting with language and speech problems, and also which neurolinguistic tests can be done to characterize the language and speech problems. And this will then allow you, for instance, to decide which subtype the patient belongs to. And as I will explain, and this has important implications, both for communication with the patient about the diagnosis, and also with regards to the expected evolution and the expected problems that may arise down the road and progression rate. So accurate characterization of the language and speech problems is important because it has also implications in what we communicate to the patient and the families and how we follow the patients. And so the subtype is closely linked to the underlying neuropathological cause, which we will come to in a minute. So the outline is relatively straightforward. We will first define the subtypes based on the Gorno-Tampini 2011 recommendations. That's more sort of introduction. But then more importantly and effectively the main purpose of this talk is to see how you as a clinician, when you are sitting in front of the patient, how you can sort of get a handle on the important functions and dimensions you need to test in the half hour or more that you are together with your patient, and which tests you can order. So the emphasis will be on the clinical and behavioral tests. So the framework for the subtyping has been established in 2011. According to this classification, there are 3 subtypes, and that I will nuance also a bit to the end of my presentation. But let's first start with the 3 main subtypes so that we all are more or less on the same page. This may be more or less familiar terrain for most of you. So the first, of course, is does the patient have a diagnosis of primary progressive aphasia? Primary progressive aphasia requires that aphasia is the main complaint and the main impaired domain, and that other cognitive domains are spared, at least during the first 2 years of the disease course. Once you have established the diagnosis of, once you have established that there's a language deficit as the main affected domain with sparing of other domains, it's important to also go further into which type of PPA. Depending on whether there's speech apraxia or agrammatism, you can decide if it is present, whether it's a non-fluent variant. If there's no speech apraxia or agrammatism, then the most distinguishing feature is whether there's a comprehension deficit. In that case, we speak about semantic variant PPA. On the other hand, if it's mainly a problem with phonological short-term memory, we speak about logopenic variant. But now by explaining this slide, I've already used a number of terms that are central to the classification, but that immediately raise the question, what does that exactly mean for a clinician? How can I detect speech apraxia? How can I test for agrammatism? What about this phonological short-term memory deficit? So what we will try to do during this hour is operationalize these heavy terms so that it becomes something that you can sort of apply directly in your practice. The subtyping itself is something we will take for granted at the moment. What we will work towards is a sort of set of instruments, clinical tools that allow you to give more substance to these terms in the blue boxes. So subtyping is important, there's no doubt about that. Primary progressive aphasia as such is not end diagnosis. At least we need to try to see which subtype it is, because that relates to the underlying etiology in a probabilistic manner. And it is important when we talk to the patient and the family who come for a diagnosis, if we communicate the diagnosis, and also what is to be expected in the future, then the accurate subtyping is the basis for that conversation. So it's terribly important. It's also terribly important for the patients and the families, of course, because losing one's language, losing the ability to speak is one of the most profound and pervasive neurological problems one can experience. It's also a rare disease, so it's not something that is very familiar for many physicians. And it's also, it also deserves definitely more attention, and because it's something that is really very important, but also quite difficult to capture for clinicians, which is why we have the current seminar, of course. We won't say too much about MRI and FDG PET, apart from that they can be useful. I will show you a couple of typical patterns, but this talk is not so much about the technical investigations, more about the clinical evaluation that you do when you are sitting together with your patients. And likewise, cerebrospinal fluid biomarker tests, of course, are essential because they allow you to determine whether Alzheimer's disease is in play or not. They are important, we often do them, but again, this talk is not about the use of this technical investigation for diagnostic subtyping, but more about the clinical evaluation by the physician. So if we want to go more into the details of the use and interpretation of the technical tests, that would be a separate seminar. So this is our next question. What is the single most frequent etiology of PPA semantic variant? And here you have 5 options. Sanja, can you put up the question?
Yes, I will just blend it in. Here it is. Okay, 15 seconds left. Okay, most of you have voted, so I will show the results.
Okay, so the correct answer was FTLD TDP43 type C. That's something that we will now explain in a little bit more detail. And so the different variants, so we have explained that there are 3 variants. The semantic variant is one of them. The semantic variant was formerly called, also sometimes still called semantic dementia. In fact, these are more or less interchangeable terms, to my opinion. So the advantage, of course, of the term PPA semantic variant when you communicate with the patients and the family is that it's not loaded with this heavy term dementia. A semantic variant PPA or semantic dementia is really a sort of distinct disease entity, and it's most often caused by TDP by frontotemporal degeneration, TDP43 depositions within the neurons with the displacement of TDP43 from the nucleus to the cytoplasm, and it affects a particular region of the brain, which is shown here on a brain of a person who donated his brain with PPA-SV, semantic variant. And you can see with my cursor that there is a shrinkage of the anterior temporal pole. This is end-stage disease. And importantly, other parts of the brain are relatively preserved, apart from possibly some atrophy of the frontal lobe. But the brunt of the damage is in the anterior temporal lobe, which can also be evidenced by FDG PET, where you have this typical pattern of hypometabolism shown in blue. It can be bilateral, it can be unilateral with predominance to the left or to the right, but it's a very characteristic disease with a characteristic microscopic signature and a characteristic distribution. It can be caused, the same phenotype can be caused by Alzheimer's disease. It happened in all expert centers that you diagnose semantic variant PPA, and then at autopsy, it turns out that the cause is Alzheimer's disease. It's definitely possible because in some cases, in atypical situations, Alzheimer's disease can also affect the anterior temporal pole. The distribution then is a little bit different. And that's the reason why, for instance, cerebrospinal fluid biomarkers are important in the workout in order to determine whether there's actually Alzheimer's disease as etiology. And we have also had situations where the microscopic diagnosis turned out to be Pick's disease, which is a tauopathy. But importantly, in the majority of cases, it is due to frontotemporal lobar degeneration with TDP43 inclusions. And there's a specific type of inclusions that is characteristic for this semantic variant, which is what we call type C. The second type, the non-fluent variant, has a different pattern of underlying causes. In the majority of patients, it is due to frontotemporal lobar degeneration with tau aggregates, and that can be corticobasal degeneration. It can be caused by progressive supranuclear palsy or by Pick's disease. But in the majority of cases, the non-fluent variant is caused by FTLD tau. In 20% of the cases, it can be due to TDP43 depositions. And again, Alzheimer's disease can also give rise to the non-fluent variant, hence again, the possible usefulness of cerebrospinal fluid biomarkers. Here you see the FDG pattern, which is clearly distinct from the semantic variant, where we see that the inferior frontal gyrus is affected, the premotor cortex also, and also to the medial side, the supplementary motor area and the pre-SMA, the pre-supplementary motor area. So a distinct anatomical pattern, and also most often a different underlying microscopic origin. And then there's the third type, and it is this third type which was mainly added in 2011 with the recommendations, the logopenic variant. And the logopenic variant is most often due to Alzheimer's disease. Again, cerebrospinal fluid biomarkers can be very useful in order to confirm Alzheimer's disease as a cause. There can also be other causes, such as frontotemporal degeneration, but this is probably one of the situations where cerebrospinal fluid biomarkers can be very useful. There's also a rather typical pattern that can also vary very much between logopenic variant patients. So it is probably the least homogeneous. The most homogeneous is definitely semantic variants. So this is more to set the scene, the background. Probably some of these aspects are familiar to you. The main purpose of this talk is to see how you can characterize clinically and come to accurate subtyping. And so there's 6 key questions where you can, if you go through them, you can arrive at a good characterization of the underlying deficits, the underlying dysfunctions, and possibly also to a correct subtyping. So the first question, is there a language deficit? Second question, are other cognitive domains relatively preserved? If question 1 and 2 are yes, then you can say it's PPA, and then there is an important distinction between word finding and speech problems. Then repetition of single words and longer sentences is something of which we have realized the importance, mainly based on this new classification, including the logopenic variants, and then agrammatism. And the 6th question is comprehension affected? The different types of tests, within the ERN-RND, we are now doing a sort of survey which tests are used in the different expert centers. You could say, well, you could say schematically, some tests are just part of common batteries for aphasia, such as the Aachen aphasia test or the Boston Diagnostic Aphasia Examination. There are also some batteries that may be very useful that are PPA specific, like the Sydney Language Battery. The difference is that these are usually validated in one or a few languages. SIDBAT is validated in a couple of languages, in contrast to the common aphasia batteries that are often available worldwide and have been validated in many, many different languages. And then, of course, there's also a couple of tests that are really only used within a particular language. And so we are currently doing a survey, and that will become available on the website of the ERN-RND, where we list the different tests, and that may be quite useful as an instrument. So of course, everything starts clinically with a history. The first thing is, what is the patient coming to seek help for? What has the family noticed that is worrisome? What are the concrete examples? Of course, in a memory clinic, people will often say, I come because of memory problems, but then it's extremely important to ask for the concrete examples. And in some situations, the person who is consulting you may say, well, I have difficulty finding the right words. And then it's important to further query which types of words, and then if it's really only related to proper names, then it may still be fitting with the cognitive aging. But if it's really words for common objects, and that is really hindering the communication and making the person feel ashamed and embarrassed because he can't find the right word in a discussion or in a conversation, and speech is also not really as clear and to the point as it was before, then it's not really memory, but actually language. And so then you have to do these additional tests that we will talk about today. An important distinction is also between language and speech, but most often in history taking, that will not be that straightforward to distinguish purely based on history. There we will need some tests. So the first question is there a language deficit? And there you can, of course, already have a good impression based on a spontaneous speech during history taking. It's very important also to have in your cabinet a pictorial scene, one of these standard scenes, such as one that I will show in a minute, where you can elicit semi-structured speech, which can help you detect certain abnormalities that may be less apparent if the person can speak freely. And then there's also, of course, other common clinical tests that can help you detect whether there are any language or problems, like you can do some of the items of the Boston naming test as a physician. I will give you some examples. You can, as a physician, ask to repeat sentences to detect language problems. And sometimes it may not be possible within your half hour of clinical examination, or within the hour of clinical examination, to feel confident that there is a language deficit. There may be something that is subtle, that the person is feeling, but that you're not detecting. And of course, neurolinguistic assessment is then very valuable also to characterize in more detail and more exact which domains are affected. Here is an example of a typical scene that we are using. This is a scene from the Boston Diagnostic Aphasia examination. I will, in each of my examples, have a spectrogram, which you can see here. You will see how the red line is moving as the person is talking. And here you have that transcription that will help you. It's a transcription in English, but the fragments are, of course, in Dutch, because we are in Flanders. And so if you look at the transcript, you can already have a good idea of what the spontaneous speech sounds like. And in the meantime, I will have you also hear the speech, and you can follow when you have a red line and hear the blue cursor where we are in this time series.
Vrouw die de afwas doet en die haar zoontje pakt, jarig, die haar zoontje pakt en dat is water. Die morst water en daar staan borden en dingen of tassen. En dat is een venster, een tuin. En die staat op een stoel, die jongen. En dat meisje staat daar naast. Op de stoel staat die jongen en die jongen valt. En dat zijn kasten.
So here you have a clear example of a non-fluent speech, and we call it non-fluent because for several reasons. First of all, the amount of words spoken is less than one would expect in a minute. The number of words per sentence and per phrase is also limited. The sentences are really short. And also there are many pauses between the words within a sentence and between sentences. So there's a clear example of a non-fluent variant where the words themselves, they are really easy to recognize in Dutch and would also be the case for other languages, of course. So the words themselves, they are spoken relatively clearly, but the tempo and the amount of words is non-fluent with short sentences and pauses. And so this is a typically non-fluent form of speech, but with pronunciation of the words that is still correct, although the sentences, they are simplified. And that may indicate also a form of agrammatism, the simplification of these sentences. This is one very useful test in the clinic to detect the fluency to determine the fluency of the speech. I will give you another example of a person who has also a hesitating speech. Here you see the transcript. There are pauses. He often says but the sentences themselves, they are somewhat more well constructed with slightly higher complexity. But what is mainly striking in this person is that he has so many hesitations during his speech and that he has difficulty retrieving the right word, even for common words. And so if somebody is not familiar with aphasia, you may think, well, it is still relatively normal. So it requires attention to these characteristics such as word finding pauses and difficulty finding the exact word with some vaguer words that are less specific in order to detect that there is an abnormality. And so I won't let him hear the entire fragment, but I will give you here in the transcript an idea. And so these are two different patients, vignette A and B, and they can be quite difficult to distinguish because I can tell you vignette A was a non-fluent variant PPA because of the non-fluent speech and also the agrammatism that she had. This person is actually a logopenic variant, and so both are hesitating, both have word pauses, both have often simplified sentences, but the speech is still different in some aspects. But the other tests that we will come to in a minute will definitely help you to distinguish these two relatively similar forms in a more reliable manner. And as I said, the logopenic variant is mostly due to amyloid and Alzheimer's disease. So our second question is, are other cognitive domains relatively spared? I will be relatively brief on this question. It is an important one, but it can be distinguished or answered in a relatively straightforward manner. For instance, history taking is very important in this respect. If there's a change in the instrumental activities of daily living, is it really attributable to language and speech problems, or is there other reasons why a person can no longer do the finances, or can no longer drive, or can no longer take medication in a safe manner? So an important factor is which problems is the person experiencing in everyday life, and can these problems be attributed to language and speech, or is there more? For instance, if a person at a turnaround doesn't know anymore which road to take, that person does not have PPA because a topographical memory problem is not part of the PPA spectrum. If a person says, I can drive and find my way, but I have difficulty if I'm in a new environment to read the signs, or to know I can't say which street I am going to, or if somebody is telling me go to that city, I have difficulty knowing what exactly is this city, then that can be PPA, because then it's more due to the language. And then another important test is the test for constructional disturbances. A test very familiar, very similar to each of us, very familiar and to each of us, the overlapping pentagons of the MMSE. If the patient has a problem when he presents for the first time with copying the overlapping pentagons, unlikely that that patient can be diagnosed with PPA, because constructional praxis is relatively preserved early in the disease. And then it may be that a person has language problems, like in left hemispheric dominant Alzheimer's disease, and also constructional praxis problems. But then we wouldn't call that person a primary progressive aphasia, because copying overlapping pentagons is not a language task. And so if that's affected early on, it's rather an indication that we may have a more atypical Alzheimer's disease with predominant language problems. In the past, it was sometimes said that, for instance, non-verbal episodic memory tests could help, like the Ray visual design learning test. But you have to be careful, because non-verbal episodic memory tests also require a degree of executive function. And in the past, we have, in the beginning, sometimes thought that because non-verbal episodic memory was affected, it was more likely to be not to be PPA, but rather Alzheimer's disease. But the executive dysfunction that can occur in PPA, for instance, in a semantic variant, may also affect non-verbal episodic memory. So that is not that reliable. I mainly go with the history and also with these relatively simple tests. Let's go to our next question. Is it a word finding problem, or is it a speech problem? And so I will give you, as you see, that most of you will recognize this, because this is part also of the shortened version of the BNT, the 15-item Boston naming test that is commonly used by the physician in the clinic. And so I will let you hear how a person with PPA pronounced this. I will again use the same principle. You have the transcript here corresponding to the spectrogram. So this is a characteristic speech problem. The target word is entirely clear and correct, but it's the pronunciation of the word that is clearly impaired, where there are pauses between the different syllables. And so these pauses between the word segments, they are pathological. So here you see this pause on the spectrogram. You could also hear it clearly. And that's indicative of a speech problem. And also you have here the hesitation before the word is spoken. There's a couple of efforts to get the word spoken. So this is not so much a word finding problem, but more a speech problem. But these speech problems also fall under the umbrella of primary progressive aphasia. For instance, in speech apraxia, you can also have these differences in timing between word segments and these efforts to initiate the word. So there is some theoretical discussion, but in practical terms, primary progressive aphasia is also used to refer to some patients who have mainly speech apraxia, like the person that we just heard. And then we are really clearly in the realm of the non-fluent variant PPA. This cannot be anything else. A logopenic variant does not show this type of word-speech problem, this type of speech problem. Let's have another example of the same person. So the problem with the timing is clearly here again between two syllables. There should not be a pause, and there is this is part of this speech apraxia spectrum where you have pauses between syllables and where you have also more effort to get the word pronounced. Let's now have another example. I will first let you hear this, then we move to, so this is another patient, and I will let you hear just one example. So again, you hear with a word that consists of different syllables. Speech apraxia is most prominent if you have multisyllabic words with consonant clusters, like this word, maiskolf. And that's a word that is pronounced in a rather difficult manner with also abnormality in the intonation and in the intonational prosody. And there's a rather characteristic pattern of pronunciation. We'll let it hear again. So again, multisyllabic words with consonant letter clusters, they are typically difficult for persons with speech apraxia. So now we come again to a question. This person also contributed to our brain donation program, and I can ask Sanya to put up the questions. So although it's limited information, we have here somebody with a non-fluent variant pattern with a speech apraxia. What would you consider the most likely outcome of the microscopy in this person? So it could also be the person that I let you hear just before. So this sort of speech apraxia with effortful speech, where there's abnormality in intonational stress, where you have pauses between the syllables. We'll let you make your choice.
"15 seconds left." Okay, so I can show the results now.
So you're really very, that's true. So the majority chose corticobasal degeneration, and that's actually what the post-mortem diagnosis was. So we see corticobasal degeneration is a rare disease, but it can present with speech apraxia of the type that we just demonstrated. And it could also have had as an outcome PSP, because these two are often difficult to distinguish. However, FTLD TDP43 would have been surprising. It could have been, but it would have been very surprising because, for instance, type C is mainly the semantic variant, while we just listened clearly to a non-fluent variant. Here I will give you another example of how this speech apraxia can sound. So these are a sequence of 3 objects that have to be named. And in the third object, you will see another type of abnormality in speech apraxia, where a simple word for apparently simple word like potlood, again multisyllabic with a consonant cluster, is really impossible for the person to sequence properly. And so you have the normal sequencing of phonemes that really has become impossible for the person to, where she has several attempts where you can recognize that she knows which is a target word, but the sequencing of the phonemes is impossible. I will let you hear this. It's a brief fragment. Oh.
Okay.
So the reason why I'm showing you this is because this is a different type of abnormality where the normal phonemic sequencing is no longer automatic, but can hardly be achieved anymore. Again, about the same very instructive naming test. So you see we have already several examples of different types of aphasia and speech problems elicited by a test that is really available to any physician. And so it's a very, very useful test in these situations. And here you see the transcript of another person with PPA, and it's of a very different kind. The person says he sees this word, he has clearly recognized the item to hang the clothes on. I have taken this morning my shirt from it, such simple things that we see daily. So this is a very different pattern. And here we are really confronted with this word finding problem, not a speech problem. So I can let you hear it. This is more difficult to appreciate if you are not of the native language, because of course the words have here been translated. But the important thing is that you have circumscriptions that indicate that the person has recognized the item, but he cannot find the right word, but he can then ultimately with some help come to the correct word. And that's a typical word finding problem, not a speech problem. So I will just let this run. The characteristic of this pattern are these circumlocutions, where you can, where the person circumscribes, that he shows that he has recognized it. He's also frustrated. So this is a classical word finding problem, not a speech problem. Here you have another example. This is a very good item to test for this type of word findings problems. He says it's an animal in the sea, a centipede, and then it's indeed a sea animal. It says 8 arm. So he comes up with circumlocutions that are indicating that he tries to find the right word, but he can't find the right word. So this is a typical pattern that we see in a particular subtype of PPA, the semantic variant. Here is another question. Which region is responsible for the deficit in this last person with his circumlocutions, and he gives clear indication that he has recognized the item, but then he says some possible words that may be related to visual similarity, like centipede or 8-arm, and then circumscribes that he has used it. I've taken it from this morning, I've taken it, but he can't find the exact right words. So which region would be involved in this type of deficit?
Okay, 15 seconds left. Okay, here are the results.
So this type of word finding problem is most characteristic of the semantic variant of PPA, which is most often due to impairment of the anterior temporal pole. So 20% of the participants said anterior temporal pole. That's correct. We have also confirmation by the PET scan, but this sort of answers in response to rarer items such as octopus or seahorse. With these circumscriptions, they are most often seen with a semantic variant. The temporoparietal junction, which was the winner among the participants, is the region that is most often affected in logopenic variant. Typically for the logopenic variant, the problems are most pronounced in spontaneous speech with hesitations and word finding problems. But when you have to find the exact word during the confrontation naming, such as the Boston naming, it often goes better than you would expect when you hear their spontaneous speech. So Sanja, can you close? All right. So here you see the scan of this person where you see the pronounced atrophy of the anterior temporal pole. So now we have come to our fourth important question, repetition. And that's something that really came more to the forefront when the logopenic variant was defined. Very important for repetition is that there's different materials that you can ask participants to repeat. For instance, if you have in patients with speech apraxia, the repetition of multisyllabic words with consonant clusters will often show the speech problems. In patients with phonological short-term memory problems, as in logopenic variant, the critical material to ask to repeat are the longer complex sentences. And so it's very important to test repetition when you see a patient. And it's very important to realize that these two types of materials, they bring to the forefront different deficits. If you have multisyllabic words with consonant clusters, it's more to detect speech apraxia as in non-fluent variant. If you ask to repeat longer sentences, it's typical to detect for detecting the logopenic variant. So in the beginning, we had, you remember maybe this cookie theft picture where they had to describe, and we had two patients which maybe resembled a little bit in their performance on their cookie theft picture. But if we would have put them to this test with repetition, with the multisyllabic words versus the longer complex sentences, it would have been immediately clear that one is more a speech problem of the kind that you see in speech apraxia, and the other is really more a logopenic variant who fails when he has to repeat longer sentences. This is a transcript of a repetition task that is part of the AAT of a person with speech apraxia. And you can see that in this person, there are clear abnormalities, even for repeating consonants or some vowel combinations or some simpler words. So this is a quite severe instance of speech apraxia, because usually that would only become prominent when you have longer multisyllabic words, but in this person, it's already present if you have consonant clusters or at the end of a word. That I have mostly dealt with already. Here, this is another person who has difficulty repeating longer sentences. And so here, this is the sentence. He went to pick up his mother with a new car in the station. And the person has really a lot of difficulty in getting this sentence repeated. That's typical for the logopenic variant, because it's a longer sentence. He can repeat the words normally, but it's the length of the sentence that causes the problem in repeating it exactly. Here is another example. The man who bought our car married yesterday, and the patient is unable to repeat this exactly, which is an impairment, which is abnormal, and which is characteristic of the logopenic variant. This patient could perfectly well repeat simpler or longer words, but he has a lot of problems repeating the complex sentences. And so the etiology in this person is Alzheimer's disease, which is the most frequent etiology in the logopenic variant. I have skipped this question, Sanya, for the sake of time. So, and now we come to the two final important things. Agrammatism is something that I will give you a brief illustration of. It's again the same person who also had difficulty with the potlood, so the phonemic sequencing. And so these are examples from the Aachen aphasia test. So you see in the examples that the person is hardly making any sentences. Here, man fishing. So she is not making any normal grammatical constructions. That's a very good test for agrammatism. In the example that I showed with the cookie theft pictures, the first person had short sentences. Well, this type of test would allow to test whether she has agrammatism. There's also another very useful test, the token test, which is also part of the Aachen aphasia test. That's something we we can come back in a later seminar, but I won't dwell on that too much. A very important question, the final question, is comprehension impaired? There are also standard tests, and if comprehension is impaired, in principle, the person would fulfill the criteria for semantic variant if there's no speech apraxia or other motor speech problems. The classical tests for word comprehension, I invite you to listen to the seminar of our colleague Robert Rusina from the Prague University in Pécs, who will talk about semantic variant in September. And so there are also standard tests for testing comprehension. And so we have come to the end of the seminar. We have sort of given some more concrete substance to the blue boxes. Of course, as you saw, there are many, many, many more things to say about these rare diseases. I'm glad that I had the occasion to give you a few examples that may be recognizable for your clinical practice. But now I would like to leave the floor for questions. There are controversies. That is also something I will save for another time. The scheme can be more complicated, but let's close here. And if there are any questions, I will be very glad to answer them.
Yes, Rik, there are. So the first question is, have you ever seen a patient with pure logopenic PPA, so without any associated cognitive disorder? and biomarkers autopsy favoring a diagnosis of AD?
So this is a very, very good question. So the logopenic variant, I explained a few typical features like repeating long sentences is really a very good test for this. But the logopenic variant is the logopenic type of aphasia can also occur in patients who have other cognitive deficits like constructional apraxia, when it's part of a more complicated picture with more deficits than only the language problem. That's by far the most common. And in fact, most often this is then due to Alzheimer's disease, but not always. So you need a lumbar puncture to see whether it is actually Alzheimer's disease or FTLD TDP-43. In our experience, it's frequent in younger persons with Alzheimer's disease between 50 and 65. And it unfortunately is also associated with a rather tragic and rapid disease course. And then you have the aphasia of a logopenic type, but that's not really what we would call primary progressive aphasia logopenic variant, because there are other domains affected from the beginning, but the word finding problem is the most prominent one. And so yes, we have, but then you have the really pure logopenic variant where you have a problem with repetition and with hesitant speech, but who is not impaired in other cognitive domains, and that is quite rare actually. And so that's a very good question, because PPA logopenic variant has also caused some confusion, because many persons with the aphasia of the logopenic type have other cognitive domains and are AD. And we call them AD because for AD we can develop specific therapies, and so we don't want to miss the underlying cause. But we have patients who have purely the repetition problem and the hesitation, and they would have the sort of pure logopenic variant with on FDG PET only temporoparietal hypometabolism. But in my experience, they are rare, and they are often, at least the ones that I'm seeing, progressing much more slowly than these what I call left hemispheric predominant AD patients. And then there's a third group, patients with logopenic variant who have normal AD biomarkers, who have probably FTLD TDP-43, and who may have also medial temporal hypometabolism, but without any clear amnestic deficit. So logopenic variant, I think what I would like to give as a take-home message is really that it's more important to characterize the problems and the dysfunctions rather than to try to push a given case into a particular subtype. It's not when we have pushed the case into a particular subtype that we can say we have a diagnosis. No, we have to test these different dimensions that we talked about today so that we have a picture of this individual case and of this individual patient. And then we can sort of say, well, this fits best, for instance, with semantic variant. I think this logopenic variant has the introduction of the logopenic variant has some blessings, but has also some disadvantages, in my opinion.
Okay, thank you. Another question, how to approach polyglot patients with suspected PPA? Do the aphasic symptoms present in all the languages at the same rate?
Yeah, that's also an excellent question. So I know that in some parts of the world, of course, people speak like 5 to 10 languages or more. In Belgium, it's mostly limited to 3 languages. It's also, but and that's a topic for further study. So we will have a postdoc coming to the lab who will study this, and I think it's an interesting, a very interesting topic from a neurobiological viewpoint. Clinically, in my experience, it's of course the native language that is most robust in most of the cases that I have seen clinically, at least. It's most often the case that it's the language that is learned second, or in which the person is less proficient, that is affected most. And of course, there's also the problem of persons presenting to the clinic who don't speak the native language of the clinic to which they go. For instance, persons who speak Persian or who speak Arab, then it's of course very difficult. And then the FDG PET and the lumbar puncture comes in very useful, because they are of course measures that are independent of the specific language, while the tests are dependent on the language. And so I think it's really, I think, a big step forward that we can make use of these technical investigations in some situations where the tests are not that useful, except if you would have other professionals who share the same language as a person who is coming.
Okay. So token test is for testing comprehension. You mentioned it in testing agrammatism. Did you mean reporter version of the token test?
So the token test is, in my experience, a test that sometimes in the beginning of the disease can be the first one or the only one that fails, for instance, in patients with non-fluent variant. And it's entirely correct that it's not strictly speaking a language test, but more a sort of working memory test. It's a test, I couldn't show you the example because that would bring us too far. But for instance, it's a test where you ask, show me the red circle and the blue triangle or the blue rectangle. And so the person has to have a working memory so that he can execute the task correctly. And that aspect of working memory is probably to a high degree related to the inferior frontal gyrus, and so is shared with is close or nearby regions that are also causing agrammatism. And so in that sense, it can be a test that is abnormal in non-fluent variant, while in some of the persons that we are seeing in the early phase, it can even be the first test that is abnormal. But I agree, it's not a grammatism test in the strict sense, but it's a sensitive test for working memory that is important for this type of multi-step or multi-component commands.
Okay. Would you perform LP in all PPAs?
That's also a difficult and good question. So I think if you have a person with a typical semantic variant and a typical pattern on FDG PET, then it could still be Alzheimer's disease, but that's less likely. And then the indication for lumbar puncture will also depend on how important is it to have a correct diagnosis in your conversation with the patient and the family. But for the non-fluent variant also, if you can have a minority that is due to Alzheimer's disease, and definitely in logopenic variant. So now in our practice, we would, in the majority of the PPA patients, do a lumbar puncture, but I can understand that if for any reason one would prefer to limit and not to do the lumbar puncture, then often in a semantic variant and a non-fluent variant, it mainly confirms your clinical diagnosis, while it's often more useful for the logopenic variant. But when, at the time when CSF-AD biomarkers were not yet available, we definitely, even for the semantic variant, we had sometimes a microscopical diagnosis that surprised us, and you also see it in the series that predate the systematic use of biomarkers, that even in academic memory clinics who are very experienced, the etiological diagnosis can sometimes differ from what you expect from the subtyping. So yes, in most of the persons that are willing and where there are no contraindications, we would do this, but it's not that there's a sort of guideline of something that we say that has to be done. The yield will depend on the type of PPA.
Mm-hmm. Okay, thank you. Another question that came through the chat early on in the webinar, if possible, would it be possible to explain how the different forms of FTD progress as the underlying diseases worsen? Almost all of the literature is focused on diagnosis and early stage therapies, but very little on how the symptoms of PPA become more like over time, more like FTD over time. And there is also almost nothing about what late stage FTD looks like versus other forms of dementia. Your clinical experience would be greatly appreciated. Thanks.
Yeah, I remember a paper from Andy Curtis from Canada who actually looked into that time aspect. And how the evolution allowed to retain the distinctions. But I think again, it's of course we follow the patients over time. If a patient presents at an early phase and we follow the patient, most often the semantic variant will have a relatively slow disease course. I think on average in our series, from the diagnosis to the demise of the patient would probably be on average around 12 years. So it's a slowly progressive disease that retains its characteristics until very late, and even with preservation of the physical capacities, the physical state of the person for a long time. The non-fluent variant, of course, unfortunately, many of those persons will eventually develop an inability to pronounce words, and then also often develop problems swallowing and other motor symptoms like falls and eye movement disturbances. And then the logopenic variant will most often, as we discussed, evolve in a more full-blown Alzheimer's disease pattern, unfortunately. So the evolution is quite distinct if you start seeing the person in the beginning. If you see a person for the first time who is already well advanced in a moderate or severe stage, then it can be particularly difficult to form a solid clinical opinion. And again, there sometimes it can certainly be of interest to rely on technical investigations like FDG PET, which often give a characteristic pattern even in a far advanced stage. So it's not the case that these diseases, that they evolve into a sort of common pattern. That's not the case at all. If you look at the brains of persons who donate their brain after death, it's really striking how selective the atrophy and abnormalities remain. And so it's really an advanced stage that often these regions of predilection are still the ones that are mainly affected, and others are still relatively well preserved. Of course, in the semantic variant, there may, of course, arise overlap with the behavioral variant. That's something that I couldn't discuss today, but so that's certainly something that is frequent.
Mm-hmm. Okay, one last question, Rik, and because we should be aware of the time. Have you ever seen in your practice PPA-OS that did not develop into PNFA or CBS PNFA in the long-term observation?
The abbreviation PPA-OS stands only speech apraxia. I have seen only one person who really remained for a long time restricted to speech apraxia with no other motor symptoms, but that's really very rare. Then in the further stages, there was also some idiomotor apraxia, but there were not the characteristic motor problems as you see in PSP or CBD. So the most frequent form is definitely the form that develops after a couple of years other neurological system impairment. And that's also why the subtyping is so important, because it helps you draw your attention. It helps draw your attention to other aspects that may arise over the time course, like swallowing problems, falls, the eye movement problems. And so that's also one of the reasons why this subtyping in the early phase is also important, because most of them evolve, and of the non-fluent variants and the patients with speech apraxia, most of them develop other debilitating symptoms over the course.
Okay, so I think one of them is very interesting. In your opinion, what would be the threshold for diagnosing a mixed variant when different aspects of language impairment coexist?
Yeah, so I didn't go into these controversies and these complications of the scheme. I had a slide at the end to illustrate this. But it's very true that before, if you would say mixed variant, that means a non-fluent variant who also has comprehension problems. And all depends, of course, on your threshold for determining is this a comprehension deficit or not. If you use one of the tests, like the Aachen-Aphasia test, comprehension, some of the items are related to non-dominant word meaning. For instance, bed, and it means a flower bed rather than a true bed. And so some of these word comprehension problems in the AAT word comprehension test may be more related to a prepotent response than to real comprehension problems. But so it's, I think the threshold should probably be to which degree is the person also experiencing and the family reporting comprehension problems, and to which degree in your clinical testing do you remark comprehension problems rather than a sort of specific neuropsychological test where the person is just above the threshold. But I think, so these controversies, they're very interesting. I haven't spoken about them today because I wanted mainly to illustrate some of the tests, but it's a good question. Yeah.
Okay, thank you. Thank you, Rik. Thank you, everybody, for asking questions, for attending this webinar. And our next webinar will be on the 18th of June. So stay safe, take care, and see you soon. Bye-bye. Thank you, Rik.